Today on Primary Care, triple negative breast cancer. Every half hour, another woman in the United States is diagnosed.
African American women already have a 42% higher death rate from breast cancer.
Hello, and welcome to Primary Care. I'm Dr. Lonnie Joe. African American women are at the highest risk for developing the deadliest form of breast cancer known as triple negative. Triple negative breast cancer, or TNBC as we call it, is more likely to be diagnosed at a younger age, to reoccur, and to have the highest mortality rate. Joining me today to talk about triple negative breast cancer and why African American women are more likely to be diagnosed is Dr. Lisa Newman. Dr. Newman is a surgical oncologist and the director of the Breast Cancer Program and International Center for the Study of Breast Cancer Subtypes at the Henry Ford Healthcare System. Dr. Newman, thank you for joining us.
Thank you, Dr. Joe.
Doctor, you have devoted your career to this terrible disease that plagues women of all types, and particularly African Americans, across the world and across our community especially. Tell me, how did you really go down this path initially in being an investigator and a surgeon and a researcher for triple negative breast cancer?
Thanks, Dr. Joe. Well, it's been an interesting journey for me. The first part of my career as a surgeon was actually as a general surgeon, where I worked in Brooklyn, New York for the State University of New York in Brooklyn. Yes. So Brooklyn is a community very similar to Detroit in terms of its strong, robust racial ethnic diversity. And while practicing general surgery, I was constantly struck by the large numbers of very young African American women presenting to me with advanced stages of breast cancers and breast cancers that were more difficult to treat. Now, back then, we actually didn't have as great, as refined an appreciation for breast cancer subtypes as we have today. And so the differences in outcome for breast cancer between black women and white women, with black women being more likely to die from the disease, was largely assumed to be completely explained by socioeconomic factors. Black women presenting with more advanced stages of disease because of delays in screening, delays in diagnosis. And we didn't really understand that there were some true biologic differences. But because of what I was seeing in my own practice, I became very motivated to pursue some of the scientific questions regarding what might be causing African American women to develop aggressive patterns of disease. And that's what stimulated me to go into surgical breast oncology. For the last 20 years or so now, I've dedicated my career to studying breast cancer disparities, and now we do see that African American women are at risk for having some of these inherently more aggressive patterns of cancer, such as the triple negative breast cancer that you mentioned. And triple negative breast cancers are defined as being triple negative because they are negative where they lack specific proteins such as the estrogen receptor, the progesterone receptor, and the HER2/neu marker. Cancers that are negative for those three markers tend to be more challenging to treat. We can treat them, and early detection is critical at achieving cures for these cancers, but they are more difficult to treat, and they are twice as common in African American women compared to white American women.
Do we know why that exists? I mean, do we know why African American women are at higher risk of developing this, or is it an access problem again that we face in so many other areas of medicine?
Well, access and socioeconomic disadvantages, lack of insurance, poverty, these are issues that threaten the outcome from any health risk, whether it's breast cancer, hypertension, diabetes, colon cancer. And so these are issues that put the African American community at a higher likelihood, greater disadvantages from outcome from those diseases across the board. But for breast cancer, we do have this added issue of African American women being at greater risk for these biologically more challenging patterns of disease. I personally believe that some of it is related to the genetics of African ancestry. And so much of my research has focused on looking not only at the breast cancers of African American women, but at the breast cancers of women that have shared ancestry with African American women, such as women from Western Sub-Saharan Africa, where we have shared ancestry because of the transatlantic slave trade from several centuries ago. And this is why my international breast cancer program involves looking at the breast cancer burden of Ghana, which is located in Western Sub-Saharan Africa. And in Ghana, we actually see that the majority, more than half of the breast cancers are triple negative. So we think that
more than half of the total types of breast cancers total is triple negative.
Exactly.
What's the percentage here in the United States?
Overall, for white American women and for European women, triple negative breast cancer accounts for about 15% of all breast cancers that are diagnosed. They account for twice as many, about 30%, in African American women and more than 50% in Western Sub-Saharan African women. So it indeed seems that extent of African ancestry is somehow related to the likelihood of getting these more challenging patterns of disease.
So in developing this project in Ghana, you discovered that the percentages were different among the native population, at least in terms of women developing triple negative breast cancer. Why is it so aggressive, and is there any difference in the aggressive nature of this disease here versus there?
Yeah. So that's a great question, and research is still underway to answer that question definitively. But triple negative breast cancer is more aggressive for a couple of different reasons. Number one, these are tumors that are inherently more likely to metastasize, to spread to other organs. And the way that breast cancer can be life-threatening is by the risk of the breast cancer metastasizing and damaging other organs such as the liver, the lungs, or the bones. Triple negative breast cancers, unfortunately, are the types of breast cancer cells that have a greater capacity for metastasizing to other organs. The other reason why triple negative breast cancers are more difficult to conquer is because of the fact that a lot of our advances in treatment for breast cancer have been related to treating the non-triple negative breast cancer, because the tumors that are positive for any of those three markers, the estrogen receptor, the progesterone receptor, and the HER2/neu marker, these are cancers that we can fight with targeted therapies. We have medical therapies that specifically focus on killing these estrogen receptor positive breast cancer cells and these HER2/neu positive breast cancer cells. And these are very effective treatments that can prolong the survival of breast cancer patients. But for a triple negative breast cancer, you cannot rely on those targeted therapies. So many women with triple negative breast cancer are more likely to require chemotherapy, because chemotherapy will kill any rapidly dividing cells. Chemotherapy has a lot of unfortunate side effects, so we'd like to avoid it if we can, but chemotherapy can be life-saving, and for women with triple negative breast cancer, it is especially likely that chemotherapy will be necessary to control that disease.
We're not doing a good job, as in most disease states, in educating the public. However, the world heard about Angelina Jolie when she had her dilemma with this disease. How are we doing in educating the African American female population? And I won't just stop at the female population. Since I'm married, I talk about the African American couple in total about this disease state.
Yeah, so you said a mouthful just then and raised several very, very important points with regard to the Angelina Jolie experience and what the media is calling the Angelina Jolie effect. So Ms. Jolie, I applaud her for using her celebrity status to get the message out to women regarding the importance of knowing your family history and knowing your own personal risk for breast cancer. Because even though breast cancer is the most common malignancy that afflicts American women, there are some clues, some red flags that identify women who might have some inherited predisposition for the disease, such as a strong family history, multiple relatives with breast cancer, or multiple relatives relatives in your family with ovarian cancer, if you have men in your family with breast cancer, these are all red flags that you might have some inherited predisposition for the disease, making it even more likely that you will get breast cancer compared to the average risk women. And if you pursue genetic counseling and genetic testing, you might find out that your risk is so high that you might want to pursue some aggressive way to avoid breast cancer, such as prevention or prophylactic mastectomy, which is what Miss Jolie did. She had the double mastectomy so that she could lower her breast cancer risk. So her experience did educate a lot of women regarding the importance of genetic counseling and knowing your family history. With regard to our addressing the African American community in terms of breast cancer risk, as you mentioned, we have a long way to go. Unfortunately, we still have to make stronger inroads in understanding the unique burden of breast cancer for the African American community, and for understanding why breast cancer is characterized by very special, unique features in the African American community. You mentioned the family effect. This is very, very relevant. Breast cancer is actually more common in African American men compared to white American men. Triple negative breast cancers are more common in African American men diagnosed with breast cancer compared to white American men with breast cancer. The fact that the breast cancer death rates overall are higher for African American women, and the fact that African American women get breast cancers at younger ages, these patterns all have implications when we start talking about the raging controversy regarding screening mammograms. I'm sure that everybody in your viewing audience has heard that there is tremendous debate regarding the age at which American women should start getting their screening mammograms.
Yes, we stirred up a little bit of a hornet's nest.
Oh, yes, yes, yes.
Good. Good. We'll continue with that as soon as we come back from a short break. We'll be right back with more Primary Care.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
Welcome back. We're here on set with Dr. Lisa Newman, surgical oncologist who specializes in treatment and diagnosis of triple-negative breast cancer. Dr. Newman, before we went to the break, we touched briefly on this controversy that is still present every day out here about mammography, who should get it, what age they should be, how effective or ineffective. We still have not resolved this to the satisfaction of the provider community, which means that the patient community is confused.
Yeah, and it's a heartbreaking confusion, Dr. Joe, because it is abundantly clear, there is no question about the fact that mammograms save lives. Mammograms absolutely increase the likelihood of detecting a breast cancer at an early stage when we are most likely to treat that cancer curatively. Now, historically, we've always said that women in the United States should start getting their mammograms every year, beginning at age 40. Some organizations, such as the United States Preventive Services Task Force, has looked back at all of the research regarding screening mammography and tried to figure out how we could be more efficient in utilizing mammograms. And this is where we start seeing some organizations recommending that women wait until they reach age 45, or as the United States Preventive Services Task Force has recommended, that women wait until they reach age 50 before getting mammograms, and that after age 50, they should even get mammograms less frequently, such as every other year rather than every year. Now, all of these differing recommendations, as you mentioned, creates so much confusion among American women. They start thinking that, well, maybe the problem is that mammograms don't work and mammograms are not effective at catching breast cancer. And that's not at all the case. Mammograms are absolutely effective at catching breast cancer early and at reducing breast cancer death rates by early detection. breast cancer risk does increase as we get older, and so mammograms are indeed more likely to show a problem when a mammogram is performed in an older aged woman as opposed to a younger aged woman. But even for women in the younger age ranges, mammograms are effective and they reduce breast cancer mortality. So all of my colleagues in the Henry Ford Health System, we continue to recommend that women start getting their mammograms at age 40 and that they continue getting them every year thereafter. This is the same recommendation that is adopted by the National Comprehensive Cancer Network and many other academic and advocacy organizations. Now, there are some women who are at higher risk for getting breast cancer who may need to get their mammograms at even younger ages or who may need additional studies aside from mammograms.
Such as TNBC?
Such as women, yes, women who are at risk for triple-negative breast cancer, and one large category of women who are at risk for triple-negative breast cancer are women who have inherited genetic predisposition for breast cancer. Women who have inherited abnormalities in certain genes, such as the BRCA1 gene, these are women who are at higher risk for getting breast cancer at younger ages, and they are at higher risk for getting triple-negative breast cancer. Women with these BRCA1 mutations and women that have strong family histories of breast and ovarian cancer, we recommend that these women start getting their mammograms at roughly 5 to 10 years younger than the youngest age at breast cancer diagnosis in their family. And these women may also benefit from getting additional studies such as magnetic resonance imaging or breast MRI in addition to mammogram. Now, an issue that has been not paid enough attention to, I believe, in this screening mammography debate is the issue of the breast cancer burden for African American women. Since African American women are more likely to get breast cancer at younger ages compared to white American women, and since African American women are more likely to get triple-negative breast cancers at all ages, but especially in the young ages, if you delay that screening mammogram for African American women, you are going to have a widening of the mortality gap that already exists between African American women and white American women with breast cancer. And we're already seeing this gap getting worse. African American women already have a 42% higher death rate from breast cancer compared to white American women.
When we come back, we want you to talk about treatment of a person who has been diagnosed with breast cancer. Stay tuned. We'll be right back with more of Primary Care. Welcome back. We're here with Dr. Lisa Newman, surgical oncologist and breast cancer specialist. Dr. Newman, talk to us about the treatment of triple-negative breast cancer.
So the basic treatment for most women with breast cancer will involve surgery, whether it's a triple-negative breast cancer or a non-triple-negative breast cancer. And whenever we diagnose a new problem in a woman's breast, the first step is to be sure of whether or not it's a cancerous problem that we're dealing with. And this is where the biopsy is so important. Any biopsy means that we are getting some tissue from the breast and then analyzing it under the microscope by our colleagues called pathologists. So some biopsies are needle biopsies of the breast. Sometimes we do surgical biopsies where we actually extract in the operating room a piece of tissue from a woman's breast. Once that cancer diagnosis has been made, there are basically 3 important principles that we have to address. The first principle is the same principle that we talk about whether it's a cancer that we found in a woman's breast or a cancer in the colon, a cancer in the lungs. You want to get rid of that cancerous growth. And this is why the very high majority of breast cancer patients require some surgery as at least one component of their care. The second principle is more unique to cancers that we find in a woman's breast, and this is the principle that the entire breast has to be treated. Treating that entire breast is important because in more than half of cases, there are microscopic amounts of cancer hiding in totally separate parts of the breast compared to where the cancerous growth was identified. So in 2016, we still have mastectomy as one form of treatment for breast cancer, which gets both of those principles addressed in one fell swoop because we are removing the entire breast. And for women who need to undergo a mastectomy, or for women who prefer mastectomy for whatever reason, we always want them to meet with the plastic surgeons to evaluate their breast reconstruction options. And our plastic surgery colleagues are wonderful at being able to recreate the breast mound, often right at the same time that the mastectomy is being performed. The alternative to mastectomy surgery for breast cancer is the breast-saving surgical approach, where we do a lumpectomy to get rid of that cancerous growth in the breast, and then we deliver radiation treatments to kill any of those hidden amounts of cancer in the remaining breast. The third principle of managing breast cancer, however, is related to the staging of the disease, and this is important regardless of whether the woman has had the mastectomy or the lumpectomy and the radiation. Overall, mastectomy and breast-conserving surgery is equal when it comes to survival from breast cancer, because survival from breast cancer tends to be driven by whether or not the cancer can ever damage other organs through metastatic spread, such as the liver or the lungs and the bones. The biggest clue regarding whether or not a cancer is at risk for spreading to those other organs is by staging the cancer via checking the lymph nodes or the glands of the underarm area. So we have to perform this staging principle, the third principle of addressing a breast cancer, by removing some of the glands in the underarm area, and this gives us a really powerful clue regarding whether or not the cancer is hiding on a microscopic basis in other organs. So if we see cancer hiding in those lymph nodes, it means we have to be aggressive with medical treatments, sometimes chemotherapy, sometimes other types of targeted medical treatments for breast cancer, treatments that will circulate throughout the body and kill the cancer cells hiding in other organs and make that woman live longer. So these basic principles are important for any patient, whether she has a triple-negative breast cancer or a non-triple-negative breast cancer. But unfortunately, the triple-negative breast cancers are more likely to require the chemotherapy.
Even though TNBC, triple-negative breast cancer, is such a deadly disease and a deadly diagnosis, at least at the outset, early detection and treatment of this disease seems to be very promising. It looks as if the women who get this disease, and particularly African American women, have a much better outcome, and they respond to treatment at a much better rate if diagnosed at an earlier stage.
Yes, thank you very much for bringing up that important point. We do not want to leave women with the message that having a triple-negative breast cancer diagnosis is a death sentence, because that is not the case. We do have good treatments, and as you mentioned, if it's caught at an early stage, it is quite likely to be treated effectively. One of the interesting and unique features of triple-negative breast cancer is related to the fact that if a woman is treated effectively for triple-negative breast cancer and she goes 5 years without that cancer returning, it's extremely unlikely that the cancer will ever come back to her. And this is different from the non-triple-negative breast cancers, where we see women developing metastatic disease completely out of the blue 10, 20, 30 years after effective treatment initially. For triple-negative breast cancers, if the woman goes 5 years without a recurrence, she's likely to never have a recurrence. It brings us right back to that important underlying message: early detection is critical. Early detection coupled with comprehensive treatment.
Excellent. Are we seeing cultural differences or the social mores that we find to some degree that exist more in the African American community than in other communities? Are we seeing that play a role in the treatment, diagnosis and treatment, and helping patients to understand triple-negative breast cancer?
There is the common perception, difficult to measure, but the common perception that in the African American community, difficulties with talking about breast cancer has led to delays in breast cancer diagnosis. There's a wonderful, wonderful breast cancer advocacy organization that I've worked with for the past 17 years now, called the Sisters Network Incorporated.
Yeah, tell us how you got involved in that. It's been a while.
The Sisters Network fabulous, fabulous women. The Sisters Network Incorporated is a wonderful national organization of African American women who are breast cancer survivors and advocates. We have 30 chapters across the country, more than 3,000 members, and the Sisters Network Incorporated conducts many different breast health awareness and education programs. They support breast cancer early detection in the African American community. They facilitate with financial obligations and treatment of breast cancer when women are under-resourced financially. They do many wonderful things. I've been involved with them since the late 1990s, and I've had the pleasure of serving as their Chief National Medical Advisor. I am incredibly proud to say that the Henry Ford Health System is going to be the signature sponsor for the National Sisters Network Incorporated annual meeting, which will take place October 20th through 23rd of 2016, right here in Detroit at the Marriott Downtown Renaissance Center.
Excellent. Excellent. That is fascinating. And a job well done. We know it's been a while. I didn't realize it was 17 years. But
it's been a long time.
That's great. That's great. And the national meeting will be here this October 2016 right here in Detroit.
Yep.
Good.
The Detroit Marriott in the Renaissance Center.
Very good. Thank you, Dr. Newman. It's been a pleasure. Thank you for joining us on Primary Care.
Pleasure's all mine.
We've just been speaking with Dr. Lisa Newman, surgical oncologist and director of the breast cancer program at the Henry Ford Health System. Keep in mind these words, that early detection equals better outcomes no matter what the disease state is. The triple negative breast cancer story for females is very, very serious, if for no other reason than it occurs at an earlier age. So early diagnosis and treatment equals a much better outcome for people with this terrible disease. For Primary Care, I'm Dr. Lonnie Joe. We'll see you next time.